Hello, good evening, everybody, and welcome to the sixth PCR CONNECT webinar of the Philippine College of Radiology. Now, for tonight, we are very lucky to have one of the very renowned speakers, a member of the Philippine Society of Neuroradiology and Head and Neck Radiology Society, Dr. Ramaan Mendoza, and she will be talking about Neuroradiology Findings in Kovid. We are also lucky for tonight because we have the president herself of the Philippine Neuroradiology and Head and Neck Radiology Society of the Philippines. She is also the past president of the CT-MRI Society of the Philippines, no other than the ever-glamorous Dr. Irma Quintanar. She will be our moderator for tonight. So she will be in charge also of the question and answer portion. So for those who have questions for tonight, for our speakers, please put your questions in the chat box that is located at the lower portion of your screen in the Zoom meeting room. Now, I will be giving the floor to Dr. Irma Quintanar, the president of the Philippine Society of Neuroradiology and Head and Neck Radiology Society of the Philippines. Dr. Irma Quintanar, are you on board right now?
Yes, Dr. Imar, thank you very much. Okay, good evening, everyone. We would like to welcome you to this neuroradiology webinar. Our topic is timely for this ongoing pandemic. So in the past, we had so many chess and long webinars pertaining to COVID-19, since most of our pertinent clinical issues are in the realm of respiratory disease processes. But this one is our very first for 2021, brought to you by PSNHNR. Sorry, can you hear me? Sorry.
Yes, Doctor, we can hear you loud and clear.
So this was brought to you by the Philippine Society of Neuroradiology and Head and Neck Radiology. So our topic is neurologic manifestation of COVID-19 with neuroradiology correlation. So we would like to thank PCR for allowing us to book this webinar so we can share it to our members. So for the PSNHNR members, this will be credited to your academic milestones, and PCR will also be giving e-certificate for this particular webinar. So we will be entertaining questions after the lecture. You can directly ask the speaker, or you can also type in your questions in the chat box. Okay, for those questions that we will not be able to answer, you can plug in your email and we will give your questions to our speaker so she can answer you directly. Okay, please allow me now to introduce our speaker for tonight. She is Dr. Maria Cristina S. Mendoza. Dr. Mendoza took her pre-medical course from UST. It is BS MedTech, and where she was awarded cum laude. And then she continued her Doctor of Medicine degree in the same university. Again, she was magna cum laude. She continued on her postgrad internship in the same hospital and institution, and also her radiology training for 4 years, where she was chief resident. Well, in 2015 and 2016, Dr. Mendoza changed gear, okay? Changed location, changed geography. She joined St. Luke's Institute of Radiology in Global City for her CT-MRI fellowship training. Well, we kind of convinced her to continue to taking up neuroradiology fellowship. That was in 2016. So she finished her neuroradiology fellowship, and she was invited at the Golby Lab Brigham and Women's Hospital, Harvard Medical School in Boston, USA, for her extended observership on functional neuroimaging and image-guided surgery. So basically, she jump-started her speakership career, lecturing career in 2015. After her neuroradiology fellowship, she propelled her lecturing engagement in high gears, now focusing in neuroradiology topics and issues, and was invited and spoke in different fora all over the country. She is now a current board of trustee of the Philippine Society of Neuroradiology and Head and Neck Radiology. So without further ado, let's now welcome Dr. Maria Christine Espinosa. Maan?
Sorry, I'm muted. Thank you for that introduction, Dr. Quintanar. Can I share my screen now? May I ask the host to please enable me to share my screen? Okay. So, good evening to everyone joining us in this webinar. My topic for this evening would be the neurologic manifestations of COVID-19 and its neuroimaging correlates. Well, the pandemic that we are in right now is caused by SARS-CoV-2 virus, which has emerged in the Hubei province of China, in the city of Wuhan in December 2019, and was declared a global pandemic in March 2020. So now, 1 year into this pandemic, as Dr. Quintanar said, I think this lecture is very relevant. Sad to say, it's still relevant because, as we know, can you try to please mute me?
Tapusan ng letter W.
Ano?
Tapusan ng W.
Oh.
Okay, sorry for that. Okay, so sadly, I think this lecture is still relevant because of the surge that we are experiencing right now. And as we know, although it's the pulmonary manifestation that is commonly presented by patients with COVID-19, there's also multisystemic involvement. And there are even patients that would present with neurologic manifestations, more prominent neurologic manifestations rather than the pulmonary disease. So about a quarter of patients with COVID-19 would present with some neurologic complaint. In hospitalized patients, there would be neurologic manifestations ranging from 6% to 36% of patients. And this is more commonly seen in severely affected patients. And as I've said, it can be an initial presentation of this disease, or it could also occur late in the course of the disease. So the proposed pathologic mechanisms by which COVID-19 may produce this neurologic manifestation is via these two mechanisms, either by direct viral invasion or secondary to indirect effects of immune activation. So let's review first. How does SARS-CoV-2 gain entry into the body? So it can either be from person-to-person transmission through direct contact or through respiratory droplets, or as we know, it can also be through fomites because of the ability of this virus to actually be present in surfaces or persist in surfaces for some time. But how does it gain entry into the CSF, into the CNS? So SARS-CoV-2 virus has this S-spike protein in its surface that binds with ACE2 receptors in different cells. So this is the reason why there is multi-system involvement. And the proposed mechanism of its entry to the CNS is first through transsynaptic propagation, wherein the viral particles that are adherent to the nasal mucosa can directly infect the olfactory epithelium, and there will be subsequent transport into the central nervous system through the olfactory nerve. Hence, we know that one of the more frequent early symptoms of COVID-19 is anosmia and dysgeusia. So this is because of the direct infection of the olfactory and gustatory epithelium, and is even considered a clinical marker for COVID-19. However, neuroimaging correlates for these symptoms are quite limited, and some that are reported in the literature would include abnormal T2 signal and subtle enhancement along the olfactory bulbs and tracts. There are also reports of microbleeds in the olfactory bulb. Of course, before we could appreciate this findings, we should be performing focused images in the olfactory bulbs and tracts, where images, thin cut coronal images. That's what they use in the literature that I was able to encounter. There are also reports of increased T2 and flare signal in the gyrus rectus. And although these symptoms are usually transient, there are reports of prolonged post-infectious anosmia. And when they did brain imaging, they found out the presence of olfactory bulb atrophy. The next mechanism by which the virus could gain entry into the CNS is through the hepatogenous propagation. So the inflammatory response of the body to this infection may cause compromise to the blood-brain barrier, through which infected leukocytes may cross, or even the virus may directly cross the blood-brain barrier. And as I have said, there are also ACE2 receptors in the endothelium. So the virus can infect the endothelium, and this may be the route of access to the CNS. So another proposed pathologic mechanism is the indirect effects of immune activation. And this pathologic mechanism is actually being purported to be the cause of many of the manifestations in the different systems of the body. So by now, I know most of you are already familiar with the term cytokine storm, which is produced by the dysregulated and excessive inflammatory response of the body to the virus. So with cytokine storm, the immune activation actually can cause, for example, hypercoagulable states that can lead to thromboembolic complications in the central nervous system. We also have to consider that the sequela of treatment of COVID-19 patients and even prolonged hospitalization may contribute in the neurologic manifestations and the imaging correlates for these patients. Okay, so now we go to the main portion of my lecture, the neuroimaging findings. So what I will be presenting here will be the more common neuroimaging findings in patients that present with neurologic manifestation that warranted imaging. So these are cases that I have personally encountered. Some of these cases are shared to me by my colleagues, and there are some that I have encountered in the literature, and I also included in this lecture because they are the more commonly reported findings. So the most common would be thromboembolic manifestations. So as I have already mentioned, the cytokine storm or the hyperinflammatory response to the virus can activate coagulation mechanisms. So the increase in the pro-inflammatory cytokines may cause endothelial dysfunction, vascular damage, and activation of the coagulation cascade, which puts the patients, especially those that are severely affected by COVID-19, in a hypercoagulable state. And this will predispose them to develop, of course, stroke, secondary to thromboembolism. So this is the most common intracranial manifestation. It is a strong prognostic indicator of poor outcome. Now, this may present by imaging as large vessel occlusion with territorial infarcts, small vessel occlusion resulting to acute lacunar infarcts, and also infarcts along the border zone or watershed infarcts. So, for example, in this patient who was admitted because of severe acute respiratory distress syndrome, as can be seen in this lung CT scan, during the course of the admission, there was progressive decrease in the sensorium. And so they opted to do a CT scan to investigate that. And here we can see cortical and subcortical hypodensities involving the right, frontal, parietal, and both occipital lobes. So these are actually infarcts along the right middle cerebral artery and both posterior cerebral artery territories. So we have encountered, at least in this 1 year into the pandemic, patients with multi-territorial infarcts. And this particular patient most likely has subacute infarct. As we can see, there are some interspersed hyperdensities that may relate to already petechial hemorrhagic changes. Another patient that we had was this. Okay, another one with moderate manifestations or infiltrates in the chest CT, but presented with left-sided weakness. So as we can see here, there is acute infarct along the right middle cerebral artery territory with involvement of the caudate nucleus, and also infarction in the right cerebellum along the pica territory. So contributing, I think also when MRA was done, is that there is presence of stenosis in the right MCA that may have contributed to the patient developing this picture or this problem. This is a patient with moderate to severe COVID, also manifesting with left-sided weakness, wherein we can see here infarctions along the internal border zone on the right side. Now, although it has been commonly attributed to cytokine storm, there are reports of young patients with no comorbidities and no significant increase in the inflammatory markers on workup that develop cerebrovascular disease. So this is one example. This patient is one example of that. This is a 32-year-old male presenting with right-sided weakness and slurred speech. The BP is normal. He is actually normotensive. This patient does not present with cough or any respiratory symptoms, but on investigation by CT scan, there was a bleed, as we can see here, in the globus pallidus, and subsequent MRI that was done showed restricted diffusion adjacent to that hemorrhage, which indicates that there is actually lacunar infarction with hemorrhagic conversion. So for these patients wherein there is really no evidence of excessive inflammatory response, what is the proposed mechanism for the development of stroke is endotheliopathy. So this is through the direct viral interaction with the endothelium, even in the absence of neuroinvasion that may result in hypercoagulability. coagulability. So cerebrovascular disease in COVID-19 may be secondary to the hyperinflammatory response from cytokine storm or endotheliopathy. Less common than infarcts or arterial infarcts is cerebral venous thrombosis, but we do encounter this also to be related to COVID-19 secondary to hypercoagulability. So this is a case that is shared to me, a 52-year-old patient presenting with dizziness and vomiting, and then eventually developed delirium and decrease in sensorium. This patient was tested positive in COVID-19, and they did a non-contrast cranial CT scan. So this is actually a non-contrast cranial CT scan, as you can already see the finding here, wherein there is hyperdensity of the venous sinuses. So particularly, the sinuses involved would be the inferior sagittal sinus, the straight sinus. There's also involvement of or hyperdensity in the internal cerebral veins, the choroidal veins, and the thalamo straight veins. And if we will look closer in the parenchyma, there is hypodensity in the left thalamus and also involvement of the lentiform nucleus relating to venous infarction. Okay. Another patient is this 35-year-old female, positive for COVID-19, but the respiratory symptoms were mild, but she complains of increasing right temporo-occipital headache, prompting performance of a CT scan. And here we can see hemorrhage at the region of the right temporo-occipital with surrounding hypodensity, and an MRI was subsequently done showing hemorrhagic venous infarction. The venography, the time of flight venography done with this patient shows loss of the flow-related signal in the right transverse sinus and also the right sigmoid sinus relating to venous thrombosis. Okay, so after the thromboembolic manifestations of COVID-19, another neurologic or neuroimaging manifestation would be intracranial hemorrhage. Now, hemorrhages or in COVID-19 is due to interplay of different factors. It may be secondary to disseminated intracellular coagulation related to cytokine storm again. We also have to consider the contribution of treatment-related complications. So some of these patients will be put into extracorporeal membranous oxygenation that can also cause derangement in the coagulability of the patient, and even put into anticoagulation, especially those that has risk of developing deep vein thrombosis, because again, we know that the COVID-19 can put patients into a hypercoagulable state. So patients with deep vein thrombosis or those that found to have pulmonary embolism may be put into anticoagulation, and this could be increasing the risk for them to develop intracranial hemorrhage. Also, presence of underlying comorbidities such as hypertension, which is also an independent risk factor in developing ICH. So the types of hemorrhage that has been reported that is related to COVID-19 can be found in any compartment of the brain. It can either be parenchymal, subarachnoid, subdural, or even microhemorrhages. So an example, patient with quite severe infiltrates on chest x-ray, presenting with alteration in sensorium. So the CT done shows parenchymal hemorrhage in the right, acute parenchymal hemorrhage in the right frontal lobe with fairly extensive intraventricular extension. An MRI was done, and as we can see, this is acute acute to subacute parenchymal hemorrhage with intraventricular extension. This is a case of a 63-year-old female that they did neuroimaging because of progressive alteration of sensorium. And what was found in the CT of this patient is the presence of subarachnoid and intraventricular hemorrhage as demonstrated in or pointed by the arrows in this image. We also encountered a case of 57-year-old female presenting with increasing severity of headache. And what we found on imaging, both on CT scan and MRI, is the presence of subdural hemorrhage in both cerebral convexities. Okay, so patients may also present with microhemorrhages. For example, the case of this 51-year-old male he was in the ICU for quite some time and presented with decreasing sensorium. And on MRI, we can see here small susceptibility signals at the subcortical regions of both cerebral hemispheres. So these are actually reported finding with COVID-19. And usually they reported that the location of these microhemorrhages are usually juxtacortical or subcortical, or even in the corpus callosum. And it is similar to critical illness microangiopathy. Of course, another consideration is that these microhemorrhages may be secondary to virus-induced thrombotic microangiopathy. So for microhemorrhages related to COVID-19, the common reported location would be juxtacortical, subcortical, and callosal. Okay, this is another patient. Another manifestation that may be related to derangement or derangement in the endothelium caused by the virus is PRES, or posterior reversible encephalopathy syndrome. So this is a patient presenting with moderate fluctuations in BP of the BP. And on imaging, we can see here subcortical flare hyperintensities in both occipital lobes that is characteristic for PRES. What is important to note is that with COVID-19, hypertensive encephalopathy may occur at lower blood pressure thresholds compared to other patients. And sometimes this encephalopathy would also present with hemorrhagic changes. And what they are attributing this to is because of, as I have mentioned, the cerebral endothelial dysfunction induced by SARS-CoV-2. So even at lower blood pressures or moderate fluctuations of blood pressures, this patient may develop PRES. And so it has been advocated that tight BP control for this patient should be done. Okay. So after the cerebrovascular cerebrovascular manifestations, we go to the infectious and inflammatory manifestations of COVID-19, which is meningitis and encephalitis. So this is less common than thromboembolic events. The pathophysiology can either be secondary to direct viral invasion or a sequelae of cytokine storm. So it can either be secondary to these mechanisms because even in patients with neuroimaging findings, the presence of virus when they tested the CSF is not routinely confirmed. So these manifestations may still be secondary to or may be an indirect effect of the inflammatory response of the patient. So it has myriad radiologic presentations. But what is reported would be this encephalopathy, wherein you can see flare hyperintensities, cortical hyperintensities on both cerebral hemisphere with corresponding restricted diffusion. So this is encephalitis secondary to COVID-19. Some would present with leptomeningeal enhancement relating to meningitis. Another reported entity would be acute necrotizing hemorrhagic encephalopathy. So this will present as hyperintensities in the bilateral thalami and even the medial temporal lobes with, as you can see, expansion of the parenchyma. And they can usually also present with hemorrhagic changes. I actually personally encountered a similar case, a 50-year-old male whose main presentation is actually headache, and that's why he consulted the ER. And only because this patient also has fever and sore throat, they did RT-PCR and tested COVID-19. So there is a known association of acute necrotizing encephalopathy in other viral diseases. So this is non-specific, but many reported cases has been associated with COVID-19 with this pandemic. Again, the mechanism of developing this neuroimaging manifestation is the cytokine storm syndrome due to blood-brain barrier breakdown because of the hyperinflammatory response to the virus. Okay. COVID-19 is also associated with white matter disease, so such as diffuse leukoencephalopathy. So the characteristic imaging finding, as you can see here in this MRI study, are multifocal or confluent white matter lesions with relative sparing of the juxtacortical and infratentorial white matter. This has been reported in patients who are critically ill and had been on long-standing mechanical ventilation and usually presents late in the course of the disease. The possible etiology for this, it's not a direct viral effect, also not secondary to the hyperinflammatory response, but more of a delayed post-hypoxic insult that causes the demyelination in this patient. So it is an indirect rather than direct inflammatory response to COVID-19. So another white matter disease that can be that was reported with COVID-19 is acute disseminated encephalomyelitis. We know that this has been also associated with other viral illnesses or seen in patients post-vaccination, usually in younger patients or adolescents. And this is a demyelinating disease that affects the CNS as an autoimmune response to these triggers. So it has been previously reported in patients infected with other coronavirus, which are members of the beta coronavirus genus, like SARS-CoV-2. So an example would be this 44-year-old male. The presentation actually is bilateral lower extremity weakness and numbness. However, this patient does not have any recent viral illness or vaccination. Also did not present with respiratory symptoms or fever. But after they did an MRI, and we can see here the hyperintense lesions in the cord, intermedullary lesions, as pointed by the arrows. And it was just as part of the protocol for admission that they did the RT-PCR, and this patient tested for COVID-19 infection. And so they are suspecting that this may be related to the COVID-19 infection. An MRI was also done for this patient. And unlike diffuse leukoencephalopathy that I have discussed before, the characteristic imaging finding for ADEM is that the lesion involves the periventricular or the juxtacortical white matter, as can be seen in these images. So there are other lesions that is also has been reported to be related to COVID-19. One of which is the cytotoxic lesion of the corpus callosum. So the characteristic imaging finding is a focus of restricted diffusion, usually involving the splenium of the corpus callosum with corresponding T2 and flare hyperintensity. So the proposed mechanism is again secondary to inflammatory damage due to cytokine storm, particularly glutamate excitotoxicity that causes this cytotoxic edema. So hence the signal changes that we saw in the MRI. Now, the involvement or the preferential involvement of the corpus callosum or its vulnerability to cytokinopathy is because of the higher density of receptors in these regions, specifically in the splenium, wherein the high density of oligodendrocyte express large numbers of glutamate-affected receptors. So that's why it's more common in the splenium, although it can also affect other parts of the corpus callosum. This is a non-specific finding, not pathognomonic of COVID-19 or even infection. It can be drug-associated or secondary to malignancy, but it has been reported to be seen in patients with COVID-19. And lastly, there can also be spinal cord manifestations in the form of Guillain-Barré syndrome, which is an autoimmune inflammatory polyradicular neuropathy associated with numerous viral infections and has also been reported with COVID-19. So the characteristic imaging finding would be T2 hyperintensity in the distal cord and enhancement of the caudal nerves as pointed in these images. So that's it. Just to give you a review of the more common neuroimaging manifestations of COVID-19, a rundown of it would be the presence of cerebrovascular disease in the form of acute thromboembolic infarcts and cerebral venous thrombosis, intracranial hemorrhage, meningitis and encephalitis, white matter disease, and the other lesions that I have discussed previously. So again, the proposed pathologic mechanism can either be secondary to direct viral invasion or more commonly indirect effects of immune activation or cytokine storm. And the sequela of treatment for this patient may also contribute in the neurologic manifestations. So we have to remember that COVID-19 is a new disease, and actually the literature available is inherently limited in size, scope, and duration. With the new variants that we now have, we don't know if there would be new neurologic manifestations and imaging correlates that we will see. Hopefully, sana wala naman, but the definitive understanding of disease mechanism and causal relationship is still very limited because, again, this is a new disease. And you have to remember that the underlying pathophysiologic processes may be concurrent and related rather than distinct and independent. This pandemic has definitely changed the landscape of the radiology practice and training. Just a supporting note before I end this lecture, I hope everybody's keeping safe and that I also encourage everybody just to check into one another and also pray for one another during this time of isolation and uncertainty. I thank the organizers for giving me the opportunity to share my knowledge this evening. And if you have any questions, I am more than happy to actually address it. Dr. Quintanar maybe can moderate the question and answer portion. These are my references. I'm sorry, before I end my presentation, I would like to first acknowledge my colleagues who contributed to this lecture, Dr. Timothy Lim for consolidating many of the cases that I presented here, Dr. Bernard Laya for the excellent resource that he provided, which serve as my one of my references, Dr. Irma Quintanar and Dr. Ron Pilitin for the cases, and also Dr. Janelle C. for collating some of the cases in one of the institutions I go to, and Dr. Vince Tatko for sharing one of the cases that I presented in this lecture. Thank you for your attention.
Thank you very much, Dr. Aman Mendoza. That was a very wonderful lecture. It was really very, very informative, and I'm sure that our audience will have a lot of questions regarding this very controversial topic. I would like to give the floor to Dr. Irma Quintanar for the question and answer. Dr. Irma.
Hello, can you hear me?
Yes, Doctora.
Thank you. Dr. Imar, thank you very much for that. We have quite a few questions in the chat box, unless somebody wants to throw in a live oral question. Are they allowed to do that, Imar?
Yes, Doctora. Yes, Doctora.
Yeah,
Pwede po.
before we entertain the questions from the chat box, we can entertain at oral questions or thrown in questions that you want. Anybody from the audience? If there will be none, then we can proceed with the questions in the chat box.
Are there any questions from our listeners? You can direct them to our lecturer. Just open your mic and unmute yourself, and then just throw in the question regarding this lecture. If there will be none, we can proceed with Dr. Irma and the question and answer.
Okay, thank you, Dr. Imar. So we will now proceed to the questions thrown in the chat box. Okay, Dr. Mendoza, our first question was, for known COVID positive PCR patients, what is the most recommended for those with mental status derangements? CT scan or MRI? Did I get that right? Yeah.
For COVID positive patients.
Yeah.
First, we have to consider, I think, the policies of the hospital. As we know, there would be some limitation into doing imaging for these patients. So most of the time, they would opt to do CT scan because it's faster. But of course, if you are, usually it's primarily first CT scan. I even know some institution that does not do MRI in COVID-19 patients because, of course, this infection and the probability of actually fomites because of the long scanning time is a concern. So most of these patients undergo CT scan. But as we know, of course, MRI would give us more information, especially for neuroimaging findings. So I am not aware of, like, for example, a clinical practice guideline that they follow as to which imaging modality to perform first. But at least from my experience, they opt to perform CT scan first before they do an MRI. Maybe if the findings are equivocal, that's when they proceed with MRI scanning.
Okay. Thank you, Maan. Maan, let me add to, let me follow up a question on that. What about in our setup? We know that we have a brain attack protocol or team in big centers. So do they still apply it as if it's a regular stroke patient?
Well, the advantage specifically in our setup is that there's a dedicated scanner for COVID-19 positive patients. So they still, at least to my knowledge, follow the usual brain attack conduct, wherein if it's ischemic stroke, they usually opt for MRI as the initial imaging at the onset. So that is because we can do that since we have a dedicated scanner for COVID-19 patients.
Okay, thank you, Maan. Okay, our next question is, are those with neuro findings in CT MRI, do they have also chest X-ray or CT scan findings too?
Most of them,
Meaning chest, right?
at least for the cases that I presented tonight, that I have encountered, they have findings. And also there are neurologic manifestations, as I have said, are more commonly seen in patients with severe COVID infection. So most of them would have chest findings as well.
Okay, thanks. Our next question is, are the CT MRI findings seen more frequently with senior or middle-aged patients?
Yes. I would say, because of course, as we know, they are also the more severely affected. And as I have mentioned repeatedly in my lecture, it is the hyperinflammatory response or the cytokine storm that can be found in the severely afflicted patients that causes these neurologic manifestations. And also, the comorbidities that is usually found in this age group can contribute to the development of the neurologic problems.
Okay, thank you. Our next question again is, for COVID positive patients undergoing MRI, would abbreviated and accelerated protocols be advised?
Like they would be taking out certain sequences from doing certain sequences.
Yes,
At
probably.
least in our practice, we do not do abbreviated protocols. We encourage, of course, dedicated protocols, depending on what you are considering. So I think as radiologists, our role really is to develop dedicated protocols, neuroimaging protocols, depending on what you are considering, so that you do not unnecessarily, even for normal cases, do sequences, prolong the scanning, and you do not really get additional information from some sequences. But we can do dedicated protocols depending on the consideration. There is no, like for example, we know that in stroke there is the BAT protocol, but for patients, COVID-19 patients with neurologic manifestation, at least as far as I know, we do not abbreviate or take out some of the sequences on MRI. If the concern is because to shorten the scanning, the disinfection would still be the same. Once you're already put in the scanner, the disinfection or the protocols in disinfection would still be the same.
Okay, thank you, Maan. I think just to add a little bit, our stroke protocol, at least in our particular center, has already been streamlined, right? Because we are trying to keep the time, which is it 15 minutes for imaging to do whatever they're supposed to do, so that they can do RTPA or thrombolysis for our stroke patients. So we already removed certain protocols that are no longer useful. Anyway, thank you for that. Our next question is, how do we differentiate the finding as related to COVID-19? I'm not sure if that's clear to you, ma'am. This is from Dr. Anatol. Yeah. Yes, go
As
ahead.
I have, yes, from other viral infections.
Probably, yeah.
Yes. It's hard if you are just going to look at the neuroimaging findings. These are non-specific. So it can be, as I have mentioned in my lecture, has been reported also to be similar findings in other viral infections. So it is very hard. So actually, they attributed this neurologic findings because of in patients hospitalized because of COVID-19 with no other maybe ongoing infection that may have caused the neurologic manifestations. So to different it, as I've said, there's no pathognomonic finding for COVID-19. The findings are non-specific and can be found in other disease entities, specifically also viral infections of the same genus as I have mentioned before.
Yeah, I think Dr. Anatole elaborated on his question, and here it is. How do we differentiate these varied findings as related to COVID-19 versus an incidental finding that is not related to the viral infection? Two separate entities altogether that clinicians will want to know. I think those are related. His questions are related.
So again, development of neurologic manifestation and the neuroimaging correlates can be an interplay of the effects of the viral infection and also, as I've said, pre-existing comorbidities of the patient, like for example, hypertension for cerebrovascular disease at least, and also effects of treatment. So it's very hard to separate one from the other because it could be really contributing to the neurologic. All those entities could contribute to the neurologic manifestations. But at least in the case of, for example, encephalitis and meningitis, and also white matter disease, if there are no other concomitant infection, as I've said, it may be safe to say that it can be related to COVID-19 because the pathophysiology of developing this neurologic manifestations is present in this viral infection.
Thank you, Maan. I think we have another question. Do we have any recent literature on neurologic manifestation related to COVID vaccine?
Oh, that I have not yet encountered. I don't know, Dr. Raif, but at least with my when I was preparing this lecture, I have not encountered any literature.
Yeah, it's just too recent, huh?
I think so.
Yes. Neurologic. I'm not sure. We masyadong mabilis, maaga pa. But what is now being discussed all around are the lymphadenopathies that are being mistaken for metastasis, which are now being differentiated from malignancy. These patients would have just recently have been vaccinated, and so they develop lymphadenopathy that are now trying to mess up with our usual cancer imaging issues. So as to neuro, yes, haven't really encountered yet. Anybody in the audience who can share about that question? You are free to share with us, so don't be shy. So that's siguro one thing, Maan, to look forward to, no? Now that vaccination is being, propelled. So the post-vaccination neurologic manifestation. So you can look forward to that topic Thank you for that question. Okay, any other question? Okay, for the immune-mediated leukoencephalopathies, when should we recommend follow-up and what to expect as part of chronic sequela of Neurokovid?
Unfortunately, for the patient that I presented, they did not do follow-up. I am not aware of a recommended follow-up for leukoencephalopathy in general. Usually, once it's documented, unless there is progression of symptoms, that's usually their guide as to whether they would do follow-up or not. But for the patient that I presented with diffuse leukoencephalopathy, follow-up was not done. Unfortunately, this neurologic manifestation is also associated with poor prognosis for the patient, and some of the patients did not actually make it, at least some of the cases that are presented there. The one with acute necrotizing encephalopathy, the bithalamic lesion, I think improved and recovered, but they also did not opt to do follow-up for that patient, because I was asking my resident if there was any follow-up imaging, even recommended MRI for that patient, but they were not able to perform it.
Thank you, Maan. I know it's these questions are hard, but like what you said, this is a new disease, so everything is not yet organized, meaning practice guidelines and recommendation, diba? Just like the older disease that we already have. So this one is quite new. So we are looking forward for this guidelines that will be coming out as the disease is being studied further now. So thank you, Maan. I'm not sure, Dr. Imar, how much time we have, because we still have quite a few questions here. Please let us know, because we don't want to take up so much of your time. But I know everyone is asking questions, because this is probably the second time we just touch on Neurokovid. I think Dr. Laya presented a little bit on it, but this is the first dedicated webinar for neuroradiology of COVID now. So Dr. Imar, do we still have time for this extra questions? Because we don't want to keep going on.
It's okay, Dr. Rairba. We can proceed with question and answer.
All
We need
right.
to also answer the queries of our members.
Yes, maybe they're very curious. So, Maan, okay ka pa,
Yes,
Maan?
yes. Doctor, just to add on to
Yes.
the previous question, actually, in the reports and in the literature that I read, they are actually recommending follow-up for these patients, because they would really want to know what the chronic effects would be. Like, for example, I have mentioned, although, again, imaging correlates for those presenting with anosmia is limited, those that had persistent symptoms and they tried to image it, they saw, or the findings were atrophy. So, of course, there's a possibility of permanent damage, cell damage, especially with, again, the proposed mechanism of direct invasion. There's also still not proven whether CNS neutropism of COVID-19, although it has been implicated because other SARS viruses has that, but there's really no evidence yet of the virus multiplying in the nerve cells. But yeah, so again, this emerging disease, I bet in the next few months we are still going to get new research, and also maybe other neurologic manifestations that are associated with COVID-19.
Okay. So our next question is, for multiple territorial infarcts, would you want to document with CT carotid angio?
Yes, definitely. Actually, it's our practice in St. Luke's, that in the brain attack protocol,
Yes.
we do neck and intracranial vessel angiography.
Okay. So next is, does the cytokine storm seen in COVID also explains the incidence of thrombotic episodes in AstraZeneca vaccines?
Again, I have not, I did not, have not encountered literature, or actually my review of literature is focused more on the effects of the virus itself, and I have not touched on the effects of the vaccine. So I'm not sure if that's what's being proposed as the mechanism in the development of the thrombotic tendencies or thrombotic problems with people vaccinated with AstraZeneca. I don't know if anyone in the audience would have any information on this. What is the proposed mechanism for the?
Yes, we do welcome comments from the audience, since we are not really the experts on COVID neuroradiology. So like what I said, this is a new disease, so everyone is welcome to comment on the questions thrown in. Okay, so I think this question was already answered. Would just like to know if in the cases shown, is there a possibility that the neuro findings may be due to comorbid or pre-existing medical problem? I think you answered this already, Ma. I don't know.
Yes, Doc.
Okay. Were there CT follow-up on these patients, the long haulers? If so, what were they?
As I've said, for the cases that I presented, they did not do CT follow-up, but their neurologic manifestations in COVID can either be the presenting symptom or present early in this disease. And there are many cases wherein it shows up late in the course of the disease. So for the long haulers, again, an interplay between the effects of the virus and even the treatment effects could cause these neurologic manifestations.
Okay. Will RT-PCR of the CSF help any studies?
Yes, there are. That the reason why one proposed mechanism for development of neurologic manifestation is direct infection by the virus is because of CSF RT-PCR positive patients. So there are cases wherein patients presents with meningitis that they do CSF tap and tested positive or COVID-19 on RT-PCR. However, there are also cases wherein this test tested negative. So that's why the indirect effect or an indirect cause, such as the inflammation secondary to the cytokine storm, is also a possibility. It's like an and or actually, Dr. At least in the literature that I because not all patients, for example, that they did CSF tap with neuroimaging findings tested positive for COVID-19 RT-PCR.
That's very informative. So given a positive RT-PCR test and with the previously mentioned CT-MRI findings, is it safe to indicate in written reports that neurologic findings can be outright COVID related or be added as part of the differential?
Well, we can say that if you have that positive RT-PCR test and it correlates with the neuroimaging findings, we can say that this may be secondary to COVID infection, COVID related. I think.
Okay.
Yeah.
So do we really put that in the report, man?
Actually, Dr.
We
Me
communicated.
personally, we communicated.
Yes, we do.
Definitely. That's actually we put the finding, like if there is diffuse leukoencephalopathy, but
Mhm.
we also still put differentials because again these are non-specific findings. Like for example, it can the encephalitis case that I presented with the diffuse
Mhm.
cortical hyperintensity and restricted diffusion can be seen
Yes.
in encephalopathy secondary to metabolic or toxic causes. So
Right.
yes,
So they are usually communicated rather than written, right?
rather than explicitly written.
Yes.
Yes,
Yeah.
or we say secondary to an infectious inflammatory process,
Right.
but not outright COVID-19.
This is different from the chest, right? Because
Yes,
with chest, you could really clearly see the
characteristic findings.
yes.
And somehow there's already a lexicon of some sort as in
Mhm.
how we should report the chest findings for COVID-19.
Yeah, I think we're getting better with that one. So I hope we're gonna get better with neuro. Okay, with COVID-19 being very common and with its neuroimaging findings being non-specific, do you think it would benefit our patients more if we insist on RT-PCR swab tests to be done for all patients prior to or right after each scan without waiting for the RT-PCR results prior to each scan to prevent diagnostic delay?
Sorry, I don't.
Did you get that? So parang
Sorry.
Um, so with COVID-19 being very common and with its neuroimaging findings being non-specific. So the question is, do you think it would benefit our patients more if we insist on RT-PCR swab tests to be done for all patients prior to or right after each scan? Kumbaga, bago iskanin, at saka, o kaya pagka-scan, RT-PCR mo, without waiting for the RT-PCR results prior to each scan to prevent diagnostic delay. Okay, did you get the question?
I think what the question is pointing at is that for patients that might be presenting with neurologic symptoms rather than respiratory symptoms.
Yeah,
So since it's not specific, I mean
right.
full range of neuroimaging findings, we do an RT-PCR so that we know if it's COVID.
Yes.
That would be very tricky, I think, because although it's very, I mean, neurologic manifestation is common, but again, um, it may be secondary to other risk factors also. I mean, like for example, if it's I mean, more common would be uh, stroke patients because there really is pre-existing cerebrovascular disease
Mhm.
or risk factors such as hypertension.
Mhm.
Uh, baka it wouldn't really be prudent to do RT-PCR for all patients with neurologic manifestations. It wouldn't
Yeah.
be practical.
But in our center, I think we do not as soon as they get admitted, they're set for a swab, right? RT-PCR.
I think in most centers, Doctora,
Uh-oh.
it is already a protocol that
Okay.
an RT-PCR swab will be done before admission.
Yes, because in the many conferences that I attend, I just want to share, aside from what Dr. Mendoza said, all, because these are all neurology conferences, all their patients, they should have RT-PCR. So I assume when they admit these patients, they already do the swab, even if and then they even do many swabs while being admitted, because we presented cases where they wanted at least 3 swab in one patient because of the I think because of the clinical symptoms of the patient. So they really confirmed 3 times if that patient had COVID. So that patient had several cerebrovascular problems pertaining to the COVID infection. So I just wanted to share that because they, at least in some centers, they really have to make sure if their patients are COVID positive or not. And they even confirm it many times because they come in negative and then eventually they get positive because of their bantay or maybe a healthcare worker or a frontliner, uh, I mean, transferred the virus to the patient. So that's why they do multiple swab in the patients that we encountered. So yeah, I hope that helped. So I think Dr. Imar, that was the last question. Thank you very much, Maan. I mean, there were many questions and we were given enough time to answer them. Thank you for that time. So again, Dr. Maan, you have many thank you messages here for your very informative lecture.
Thank you
Just,
also. I hope,
yeah,
yes.
go ahead.
It's, I mean, when I was doing this lecture, I was actually quite overwhelmed with the different manifestations that is being linked to COVID-19. So I actually, even with that myriad of neuroimaging correlates that I presented, it's already narrowed down to the more common ones that I encountered in the literature. But there are some that is somehow quite characteristic. I mean, of course, the most common still would be thromboembolic infarcts. I think that's I don't know, doctor. At least in my experience, that's what I have
Yes.
encountered more commonly. And there are some that has characteristic imaging findings. For example, the location of the microhemorrhages,
Mhm.
and again, specific encephalopathies like the acute necrotizing um, hemorrhagic encephalopathy,
Mhm.
which I also encountered personally. So, and then there are many reports of that also in the literature. So
Yes.
I think at least we have now an idea of what are the common manifestations. And when you see that, especially if the patient is COVID-19 positive, we can consider that this may be related to the viral infection.
Yes. Okay. Thank you, Maan. I think uh, you took on this challenge. So just for everybody's information, this lecture should have been given way before, but there were so many things in between. So and we wanted it. We wanted to collate our cases so we can give you a good webinar. And thank you, Maan. Finally, you gave the lecture.
Yes,
Thank
Doctora,
you.
I know. But you know,
Pasensya na
I
kayo.
remember our conversation when we were trying to finalize the date for this lecture, and I was saying, yes, we have to do it, Doctora, because vaccines is being rolled out, and this may be irrelevant. And I remember you telling me that you prefer irrelevance rather than active relevance.
Yes, yes,
Sadly, this is our situation with the ongoing surge of cases right now.
yes. So
So,
thank you, Maan, and we would like to thank. Yes, we would like to thank PCR and Dr. Imar for giving us this opportunity to share our cases. Ano pa, and for these wonderful people who are here to listen, and we learn from your questions. So we would just like to announce a few things for Philippine Society of Neuroradiology and Head and Neck Radiology. We just inducted our first members, and they are pretty much all here because it's part of our academic standing that we require from them. And we invite everyone to join us in our society. We are open for membership. We are not advertising, but we are inviting. We also have a fellowship training program. Our first is St. Luke's, and we would like to have other training centers in the future. We're still talking about it and consulting with PCR. So what else? I think because of the pandemic, we have halted some of our plans for physical conferences. But we will be coming up with webinars that are neuro related. So thank you very much. I think that will be it, Dr. Imar. Anything else that you want to say? Thank you, everyone.
Yeah. Yes, to Dr. Mendoza, thank you very much for gracing this PCR Connect this afternoon. It was a very exhaustive discussion of neurological findings of COVID. I'm sure after this webinar, your fans club will be growing ever like your K-pop BTS group. We would like also to thank Dr. Irma Quintanar for gracing this event that we have this afternoon. And to our viewers, we would like to invite you to our next PCR Connect webinars in the upcoming days to come. If you have suggestions, if you would like to volunteer to be a speaker in our PCR Connect, please do so. Don't hesitate to get in touch with our PCR Secretariat, or you can just give me a message through Messenger, Viber, or even FB. And after this, we would like to thank you again. We are going, by the way, to give everybody an e-certificate or an electronic certificate. This will be useful when you apply for a certificate of good standing from our college, which you will be using for your PhilHealth accreditation. And with this, I am Dr. Emerson Alepanyo, the Vice President of the Philippine College of Radiology. Would like to thank you and bid you farewell and hope that everybody will be safe in the coming days. Again, thank you very much and God bless to everyone.
Imar, how do we confirm
Yep.
our attendance? I'm sure people are curious. Is this
Yes.
is this good enough, or is it recorded already?
It's recorded, Doctora. Two, we have a list of all of the registrants, which we will be sending the e-certificates. We'll probably be starting this this week or probably next week after the lockdown. And then rest assured that if you have registered, you are here in the registration form and you will be receiving the electronic certificate.
Is it through email?
Through email, Doctora.
Okay,
through email.
great. Thank you
Yes.
very much. Good night.
Any other words, Doctora?
Wala na po. Thank you, Dr.
Okay.
Imar.
Thank you very much. Maraming salamat po sa lahat. Thank you very much.